Now, they have a bunch of panaceas they think that will get them to that. First of all, mandatory health information technology. This is already law, by the way. $20 billion has been appropriated for it as part of the stimulus package. Pay for performance programs, disease management programs, comparative effectiveness research, which is also part of the stimulus package. They appropriated $2 billion for that. Mandatory coverage and insurance exchange, expansion of Medicaid and SCHIP, and cuts in Medicare. These are the essential ingredients of all of the health reforms that are currently in Congress. They vary in their details, but they all contain this stuff. Problem is that the evidence says that none of this works. It has been tried, and it is proven to have failed. Mandatory health information technology. The United Kingdom is way ahead of us in this regard. In 2002, they appropriated £2 billion to wire up the National Health Service and get everybody into an electronic, interoperable information management system. Well, a recent report to the Parliament said that as of today, it is 600% over budget, 5 years behind schedule, and will probably never be implemented. They hired 3 vendors to put this system together. 2 of them have dropped out of the program, throwing up their hands saying, we can't do it. It's too complicated. Top-down centralized information systems never work very well. The federal government doesn't do it very well. They try to do it with the IRS and with the FBI and the FAA. And in every single case, they waste billions and billions and billions of dollars and have no positive result. All of the evidence says it doesn't work. The Archives of Internal Medicine published a study in 2007 that looked at 1.8 billion ambulatory visits between 2003 and 2004 and found no difference in 14 of the 17 quality indicators they were using. They concluded that the use of electronic health records resulted in significantly better quality in 2 indicators and significantly worse quality in 1. Esther Dyson had an article in Health Affairs. Esther Dyson is one of the most brilliant people of our time of whom you've probably never heard. She is a technology guru and investor, and she knows this stuff in and out. She says government standards won't make it happen. Rather, it will be pretty much happening by the decentralized efforts of millions of people. All of the evidence says that this massive centralized health information technology thing will be wasted money flushed down the toilet. And by the way, it's your money that's being wasted. Pay for performance sounds like a good idea. You pay doctors more when they do well, and you pay them less when they don't do well. What could be wrong with that? Well, in fact, all of the programs that we've tried haven't worked. Massachusetts did a massive study, over 5,000 doctors over a 3-year period, 5 million patients, 13 measures developed by the National Committee for Quality Assurance. Non-incentivized physicians improved their practices more than the ones that were being incentivized with the pay for performance program. All the doctors improved their practice, but the ones that were not being incentivized improved them more. New York State, they decided to issue report cards on cardiac surgeons. 63% of the docs reported that they started accepting the healthier patients more in order to improve their scores on the report cards. Duke University, 100,000 heart attack patients in 54 pay-for-performance hospitals were compared to 446 control hospitals. There was no significant improvement through the pay-for-performance program. In California, Pacific Care did this for 15 years. Out of 6 measurements, 1 improved and 2 were worse for the pay-for-performance doctors. Disease management programs. The Medicare program has been testing this. They've been doing demonstration projects. They had 300,000 beneficiaries in 35 different demonstration projects. The final evaluations on 20 of the programs found only 3 with any evidence of quality improvement at or near budget neutrality. It does not save money. Comparative effectiveness research. This is also based on what the UK has been doing. Now, the United Kingdom calls their program NICE, which is an acronym for the National Institute for Clinical Effectiveness. I figure in the United States, we're going to call it the Comparative Effectiveness Research Commission of the United States, which acronyms to circus. So we'll put our circus up against their NICE any day. In the UK, patients with kidney cancer have been denied 4 life-saving drugs. The director of NICE said, although these treatments are clinically effective, regrettably, the cost to the National Health Service is such that they are not a cost-effective use of NHS resources. In the United States, we recently developed guidelines for diabetes care that were widely adopted, but dropped after a large federal study indicated that lowering glucose too quickly or too much in some patients could harm or even kill them. Seemed like a nice idea at the time. Whoops. Mandatory coverage. This is one of my favorite topics. All these folks are uninsured, so let's pass a law requiring them to have insurance. Problem solved. No sweat. Only problem is that mandates don't work. They talk about auto insurance a lot and how well we mandate auto insurance, don't we? Why shouldn't we mandate health insurance? And in fact, 47 states do mandate auto insurance coverage for motorists. And in those 47 states, about 15% of all motorists are uninsured, even with a mandate. You can't just wave a wand and tell people to do what you want them to do. When you look at the history of mandates, the 55-mile-an-hour speed limit is a good example. It is universally violated. We are a nation of outlaws because every one of us violates the 55-mile-an-hour speed limit. If you obeyed that speed limit, all of the other motorists on the highway would be yelling and honking at you and throwing things, and you'd be creating road rage probably. And why? Free riders are not a huge problem. They account for approximately 3% of all of the costs in the healthcare system, uncompensated care due to the uninsured. 3%. That's chicken feed. I mean, most department stores lose more than that to shoplifters. This is not an unbearable burden for the healthcare system. In fact, a much bigger burden is the uncompensated care resulting from underpayment by Medicare and Medicaid. That eclipses the uncompensated care problem due to the uninsured by 300%.